Good morning. Welcome to this session of reproductive system pharmacology. Today, we will examine the pharmacology of the anti-estrogens. And after this session, you should be able to classify anti-estrogenic drugs, describe the mode of action of selective estrogen receptor modulators, explain the tissue-specific effects of the selective estrogen receptor modulators, outline the main clinical uses and contraindications of anti-estrogens and selective estrogen receptor modulators. So after the session, you should be able to handle a question, for example, one that is shown here. Which of the following statements is not true in regard to clomiphene? A. Women with anovulatory subfertility due to polycystic ovary syndrome can be successfully treated with clomiphene. B. The risk of multiple pregnancy in ovulation induction with clomiphene is around 30%. C. Clomiphene can trigger postmenopausal vasomotor symptoms such as hot flashes. Clomiphene is not indicated for the treatment of premature ovarian failure, characterized by depletion of ovarian follicles and elevated FSH levels. We'll see that question at the end of the class. So what are anti-estrogens? The anti-estrogens are drugs that block the actions of estrogens, and the anti-estrogens may be classified according to several schemes. One way of classifying them is the one indicated here, in which you can group the anti-estrogens as selective estrogen receptor modulators, and secondly as estrogen synthesis inhibitors or aromatase inhibitors, thirdly as estrogen antagonists, and lastly estrogen receptor downregulators. The selective estrogen receptor modulators, which are abbreviated as SARMs, are very important drugs that have found uses in many areas. We shall look at those. And these are compounds that have estrogen agonist effects in some tissues. And in other tissues, they act as partial agonists or antagonists of estrogens. Why do we require selective estrogen receptor modulators? As noted in the previous class, estrogen have a variety of beneficial effects. For example, they play a critical role in the reproductive system function and development. However, estrogen have a number of detrimental effects. For example, estrogens are implicated in the development of breast and endometrial cancers. And therefore, the drugs that selectively block the adverse actions of estrogen on those tissues, we've seen beneficial and adverse effects. What you require is drugs that preserve the beneficial effects of estrogen. For example, the effects of estrogen on the brain, the effects of estrogen on plasma lipids, the drugs that preserve bone density, and drugs that do not stimulate the uterus, which is an adverse effect of estrogen. So you want drugs that have beneficial effects and do not have the adverse effects of estrogen. So there's really no ideal SARM. We look at a selection of SARMs that are in the market. There's none that is completely ideal. So the examples of SARM include tamoxifen, which is a very popular drug in management of breast cancer, toromifene, which is very similar to tamoxifen in structure. The only difference actually is a chlorine atom. You see the one marked Z. and raloxifene. How do they act? What is the mechanism of action of selective estrogen receptor modulators? The selective estrogen receptor modulators act by binding to the estrogen receptors. In the previous session, we saw that estrogen binds to estrogen receptors. The estrogen receptor, if you look at its molecular structure, it consists of three main domains. One, the one in the center there, is called the DNA binding domain because it binds to the DNA sequences. Then you have the hormone binding domain, also called ligand binding domain, onto which the estrogen, the hormone, or the anti-estrogen binds to. And then you have what the AF domain, or activation function domain, upon which transcription factors bind. So just like we saw last week, if you are to compare the action of estrogen and selective estrogen receptor modulators, estrogen binds to its receptor called the estrogen receptor. This may be estrogen receptor alpha or estrogen receptor beta. Upon that binding, there is dimerization of the hormone receptor complex. And this dimerization leads to exposure of the DNA binding domain. The DNA binding domain has a region that is called zinc fingers, which is a motif, and it uses the zinc fingers to bind to the target DNA sequences. Those target DNA sequences are called estrogen response elements, as are shown here. This dimerization and the binding of the hormone also facilitates the binding of a number of cofactors or co-activators, which promote the transcription of target genes. So generally, that's how estrogen works, and you saw that. For the selective estrogen receptor modulators, represented here by an S, the mechanism of action is quite similar. So the selective estrogen receptor modulator, for example, tamoxifen, will bind to the estrogen receptor. The anti-estrogen receptor ER complex dimerize, and that leads to exposure of the DNA binding domain, and that binding also facilitates the binding of a number of transcription factors. In this case, the transcription factors are mainly co-repressors rather than co-activators. And an example of a co-repressor is what's called a nuclear factor co-repressor or NCO. So therein lies the difference in the molecular action. There may be also differences in the type because we have that the SAMs have different effects on different tissues. So the SAMs, their tissue selectivity may also be dependent on the type of estrogen receptor that it binds, because we've seen there are two isoforms of estrogen receptor, ER alpha and ER beta, which are differentially expressed in different tissues. So the binding of the anti-estrogen to the type of estrogen receptor may also give a different effect in a different tissue. So that gives you part of the reasons why you have tissue selectivity of the selective estrogen receptor modulators. So let's look at briefly at some of those SAMs. Tamoxifen, which you've said is quite commonly used, very popularly used in our setup, has anti-estrogenic effect on breast, but it has estrogenic action on plasma lipids, bone, and endometrium. So the anti-estrogenic effect on breast is beneficial because that's how you use it as an anti-cancer agent. The estrogenic effect on plasma lipids and bone are also quite beneficial. However, the estrogenic effect on the endometrium is not beneficial because it leads to proliferation of the endometrium, and which may lead to uterine cancer. So this is a further illustration of how tamoxifen, the tissue selectivity of tamoxifen. So you see, for example, that when it binds to the estrogen receptor in the breast, then there's no proliferation. However, when it binds to the estrogen receptor in the endometrium, there is activation and proliferation of the endometrium. The other example is so the tamoxifen. So we may look at its clinical uses. So it's used in the management of estrogen-dependent breast cancer. It is also used in the prophylaxis of breast cancer. Some of its adverse effects are related to its impact on the estrogen receptor. So, for example, in the endometrium, we've already said it leads to proliferation of endometrium. It's also called endometrial hyperplasia, and that may predispose to cancer. It may cause venous thrombosis, hot flashes, and weight gain. The other SAM, toromifene, has similar profile and similar pharmacological properties as tamoxifen. Raloxifene, on the other hand, has anti-estrogenic effects on breast, just like tamoxifen. However, it has anti-estrogenic effects on the endometrium. You saw that tamoxifen has estrogenic effect on the endometrium. It has a partial agonist effect on the bone, and it will increase serum HDL, which is a positive effect. Like tamoxifen, some of its adverse effects are related to its anti-estrogenic actions, so hot flashes, nausea and vomiting, headache, breast soreness, vaginal bleeding, and nervous tension. And that mainly goes for, that's tamoxifen-like effect. So the other category of the anti-estrogens are estrogen antagonists. And the main example here is clomiphene, which again is a popular drug. Clomiphene has antagonist action at the estrogen receptors in the pituitary. That inhibition of the pituitary estrogen receptors prevents the negative feedback effect and increases the output of the gonadotropins. So the gonadotropins, as we saw last time, FSH and LH increase when clomiphene is given. The result of this is that FSH and LH stimulate ovulation, and therefore clomiphene is used in the treatment of fertility in anovulatory women, for example, women with polycystic ovarian syndrome. Clomiphene, though, is not helpful in females in the ovarian follicles have been depleted, for example, in premature ovarian failure. The adverse effects of clomiphene include ovarian enlargement, ovarian cysts, hot flashes, mood swings, and clomiphene is helpful in about 40% of women, but in those women, the incidence of multiple pregnancy is about 10%. That is, you have twins and triplets in about 10% of the women who have received clomiphene treatment. The other category of the anti-estrogens are aromatase inhibitors. Aromatase inhibitors are agents that inhibit the enzyme aromatase, just like its name says. The aromatase enzymes is involved in the conversion of testosterone to estradiol. If you can see the one in red, testosterone to estradiol, and androstenedione to estrone. So those aromatase inhibitors block the final step in the biosynthesis of estrogen. The aromatase inhibitors may be classified into type 1, which are steroidal, and these include testolactone, fomesten, and exemestane, and type 2, which are non-steroidal, for example, anastrozole, letrozole, and fedrozole. The aromatase inhibitors have found many similar uses like tamoxifen, and also in others like clomiphene. So for example, like tamoxifen, they may be used in the treatment of breast cancer, and like clomiphene, they may be used in fertility, treatment of fertility. The adverse effects of clomiphene of aromatase inhibitors are related to the anti-estrogenic effects. So for example, vasomotor symptoms such as hot flashes, nausea and vomiting, headache, night sweats, mood swings, and decreased bone density. We then turn our attention to the last category, which are the estrogen receptor downregulators. And here, one drug which has been found to have some clinical use is fulvestrant. And this is a pure estrogen receptor antagonist that has anti-estrogen effects on breast, endometrial tissue, and the bone. So it binds to the estrogen receptor with very high affinity. You can see that it has purely anti-estrogenic effects, and that means therefore that it blocks the beneficial effects of estrogen, and therefore it has only limited use, and it's used, for example, in the treatment of metastatic breast cancer that has progressed despite anti-estrogen therapy. So therefore, that brings us to the end of this session. So in this session, we have examined the pharmacological actions of the anti-estrogens, their effects on various tissues, and their adverse effects. So with that, we can then look at this question. Which of the following statements is not true in regard to clomiphene? A, women with anovulatory subfertility due to polycystic ovary syndrome can be successfully treated with clomiphene. We've seen that is true because that's one of the indications of clomiphene. The risk of multiple pregnancy in ovulation induction with clomiphene is around 30%. We saw that that's around the incidence of multiple gestation after induction with clomiphene is about 10%, really is around 7 to 10%. So this is not true. 30% is really 3 times the risk. Clomiphene can trigger post-menopausal vasomotor symptoms such as hot flashes. So this is true because it has anti-estrogenic effects, and clomiphene is not indicated for the treatment of premature ovarian failure characterized by depletion of ovarian follicles and elevated FSH levels. This is true because where there are no ovarian follicles, such as in premature menopause, then clomiphene will not have an effect because it has effect through stimulation of maturation of ovarian follicles. So if ovarian follicles are not there in the first place, then the clomiphene will not be helpful. So that is it. Thank you and have a good day, and see you in the next session.